All right, everyone, let's talk about anemia. This is a term you are going to see all the time. I mean, it doesn't matter what field of medicine you end up in. But here's the thing, it's so much more than just a number on a lab report. Think of it as a critical signal, a message your patient's body is sending you. And today, we're going to figure out exactly how to read that signal.
You know that feeling, right? That deep down exhaustion where it's not just about missing a few hours of sleep, it's a total, complete drain. Now, what if that feeling wasn't just in your head? What if it was actually a crisis playing out in your blood? This question, this right here, is the very heart of anemia. It connects something we all understand, fatigue, to a critical breakdown in our physiology, something happening at the cellular level.
Okay, so let's get a really solid, precise definition down. Anemia is not just about having low blood. That's way too simplistic. What it really means is that the body's oxygen delivery system has failed. And you have to remember, every single cell in your body is screaming for oxygen to do its job. So when that supply chain breaks down, it's not a small problem. The whole system starts to suffer.
Okay, here's how we're going to break this down today. First, we'll nail down what anemia really is. Then, we're going to sort all the possible causes into three big buckets: losing blood, destroying red cells, and a failure to make them in the first place. After that, we'll get into the fun part, how we play detective and analyze the clues. And finally, we'll wrap it all up by reframing how you think about this, seeing anemia as a symptom, not the disease itself. Sound good? Let's go!
All right, first up, what exactly is anemia? This is about more than just a number on a CBC. We're diving into the pathophysiology here, and it's a really dynamic process. It's like a constant conversation happening between your patient's tissues, their kidneys, and their bone marrow.
You know, the body has this incredible built-in response when oxygen levels drop. It's fascinating. When tissues aren't getting what they need, the kidneys, they act like a sensor. They release a hormone called erythropoietin. We call it EPO. Think of EPO as an emergency SOS signal sent straight to the bone marrow, which is basically the body's red blood cell factory. The marrow gets the message and immediately ramps up production, pushing out these brand new fresh red cells called reticulocytes. It's a really smart, self-regulating system.
Now, there are dozens, maybe hundreds of things that can cause anemia. It can feel overwhelming. But to simplify it all, we're going to use a really logical framework. I want you to think of your entire red cell mass as being held in a container. And there are really only three ways that container can become empty. I call them the three buckets, and they represent the three fundamental ways things can go wrong.
Bucket number one, you're losing them. Blood loss. Pretty straightforward, right? Red cells are physically leaving the body. Bucket number two, you're destroying them too fast. This is called hemolysis. The cells aren't leaving the body, but they're being broken down inside the body way before their 120-day lifespan is up. And bucket number three, your factory isn't making enough. This is a production failure. The bone marrow, the factory, it just can't keep up with demand. That's it. Every single case of anemia you will ever see can be traced back to one, or sometimes a combination, of these three fundamental problems.
Okay, let's dive into that first bucket, losing blood. Now, this might seem super simple, but the way a patient presents is completely different depending on how fast that blood is being lost.
Okay, let's look at acute bleeding. Think trauma, a major surgery. The immediate life-threatening danger there isn't actually the anemia, it's the loss of blood volume. It can lead to shock very quickly. And interestingly, the full-on anemia, the low red cell count, it doesn't even show up on the labs for a day or two. Now, chronic blood loss, that's a totally different beast. It's slow, it's sneaky. Imagine a small, persistent bleed in the GI tract. The body has time to compensate for the volume loss so you don't get shock. But what you are losing day after day is iron. And eventually you just run out. This depletes your iron stores and leads straight into an iron deficiency anemia, which is actually a type of production failure anemia. See how they connect?
All right, on to bucket number two, red cell destruction. We're talking about the hemolytic anemias. In this situation, the red cells aren't leaving the body, but they're being torn apart and broken down way too quickly. So when these red cells are getting destroyed before their time is up, that same feedback loop we talked about kicks into high gear. Low oxygen triggers the kidneys, which sends that EPO signal to the bone marrow to work overtime. Now, this state of hyperactivity in the marrow, we have a name for it: erythroid hyperplasia. Hyperplasia just means more cells are being made. And what's the result? You see a huge surge of new red cells, those reticulocytes, in the blood. So here's a key takeaway.
If you see a really high reticulocyte count, your mind should immediately jump to hemolysis. It's a massive clue.
And that brings us to our third and final bucket, production failure. Anemia of diminished erythropoiesis. In these cases, the problem is squarely with the factory, the bone marrow itself. Either it's missing the essential raw materials or the production line machinery is broken.
Let's compare two of the most common types of production failure you're going to see. First, iron deficiency. This is the single most common nutritional deficiency in the entire world. It's simple. The bone marrow factory just doesn't have enough iron to make hemoglobin. The shelves are bare. Now contrast that with the anemia of chronic inflammation. This is probably the most common anemia you'll see in hospitalized patients. In this case, the body has plenty of iron. In fact, iron stores are normal or even high. But a pesky protein called hepcidin essentially locks that iron away, making it totally inaccessible to the marrow. So in one case, the shelves are bare. In the other, the storeroom is locked, but the result is the same. Production grinds to a halt.
Okay, another really important type of production failure is megaloblastic anemia. Now, this is a classic. It happens when you have a deficiency in either folate or vitamin B12. And here's why that matters. Those two are absolutely critical for making DNA. So without them, the young red cells trying to grow in the bone marrow, they can't divide properly. They just get bigger and bigger, becoming these large, weird, abnormal cells. We call these dysfunctional giants megaloblasts. And when you look at a blood sample, you see it right away. Unusually large red cells, we call them macroovulocytes, and you also see these very strange-looking white blood cells called hypersegmented neutrophils. These are huge clues.
Okay, so we've got our 3 buckets of causes. But how do you figure out which bucket your patient fits into? Well, this is where the detective work begins, and it all starts with a simple blood test that gives us our first critical set of clues. These are what we call the red cell indices, and the first one, the most important one to look at, is the MCV. That's the mean cell volume. It's just a fancy way of saying the average size of the red blood cells. Are they too small, what we call microcytic? Are they too big, macrocytic? Or are they just right, normocytic? This one number is huge. It immediately helps you narrow down the list of possibilities. The RDW is also pretty helpful. It tells you about the variation in cell size. Are they all uniform, or is there a mix of big and small? That's another great clue. So after you've looked at the numbers, the next step is to look at the blood itself. You do what's called a peripheral blood smear. This lets you see the actual red cells up close, under a microscope. And you're looking at their size, their shape, their color. Are they pale? Are they shaped like sickles or spheres? These visual details give you an absolute wealth of information that the numbers alone just can't provide. And this is where it all clicks into place. You see small, pale cells, microcytic, hypochromic, and your brain should immediately think, this is a problem with making hemoglobin. This looks like iron deficiency. Or you see big, fat, oval-shaped cells, macrocytic, and you think, aha, this looks like a problem with DNA synthesis. I need to check folate and B12 levels. You see? It's a really clear, logical path from the lab data right to a diagnosis.
Okay, let's pull all of this together now for the big picture. And this is so important to remember. In almost every single case, anemia itself is not the final diagnosis. Think of it as a giant flashing signpost. It's a critical message from the body telling you that something else is wrong, something deeper.
So yeah, fatigue is pretty much universal with any type of anemia, but other signs can point you to the right bucket. For instance, if your patient has jaundice, yellowing of the skin and eyes, that's a classic sign of red cell destruction, of hemolysis. Or what if you see signs of iron overload? That can be a clue that red cell production is failing and the body is just storing iron it can't use. And get this, in some really severe congenital anemias, the bone marrow works so hard for so long trying to compensate that it can actually expand and change the shape of the bones. It's incredible.
So I want to leave you with this thought. Finding anemia in a patient isn't the end of your investigation. It's the absolute beginning. It forces you as a clinician to ask the most important question. Why? Why is this patient bleeding? Why are their cells being destroyed? Why is their factory failing? The answer to that question tells the real story about your patient's health. So the next time you see that low hemoglobin value on a lab report, don't just see a number. Stop and ask the question, what is this patient's body trying to tell me?